This video continues Chapter 21 of Outdoor Emergency Care with spine, brain, and nervous system injuries, specifically focusing on patient assessment for those injuries. Our objectives are to describe how to properly assess a patient with a brain or spinal cord injury. Now, signs and symptoms of a traumatic brain injury may include an initial period of unresponsiveness or persisting altered mental status. It may be accompanied by headache, nausea, and vomiting, or pupillary dilation. More severe traumatic brain injuries may be accompanied by posturing or paralysis, or evidence of a skull fracture such as raccoon eyes or battle sign. Conditions with signs and symptoms similar to TBIs may include hypoglycemia or drug or alcohol ingestion, so consider other possibilities before concluding the problem is a TBI, and accompany your scene size up and determination of MOI into your evaluation. Now, previously, many patients with neck or back pain were automatically strapped on a long backboard. We referred to this as spinal immobilization, but you truly cannot completely immobilize the spine in a pre-hospital setting. So our updated terminology is to refer to spinal motion restriction. In unresponsive or altered mental status patients, you should initiate spinal motion restriction and maintain that throughout assessment and treatment. In the case of a patient needing CPR, begin one-person CPR as this takes priority as a life threat. If two patrollers are available, one may provide spinal motion restriction as the other initiates CPR. Now, in evaluating the spine for a conscious or alert patient, that patient may often be directed to just limit their movement of the spine. You may say, please don't move your head, please focus on a distant point, and be sure not to move your head, neck, or spine during this time. The assessment of a patient with a suspected CNS injury should include a complete exam of the skull, spine, and nervous system. The first decision may be whether or not to remove the helmet. It is recommended that you remove a helmet only in the case of a life threat such as the patient not having a patent airway, or if helmet sizing will limit you from initiating spinal motion restrictions. Now, in that physical exam, we can begin our head-to-toe exam with palpation of the head or skull and each vertebrae going from the cervical region to the top of the sacrum. We're looking for a step-off, which, using our assessment acronym of DCAP bottles, would simply be a deformity, or we may look for midline tenderness. A neurologic evaluation includes our responsiveness as part of our primary assessment, looking for motor or muscle strength, and function of the eyes. In our primary assessment, we can use the AVPU scale to determine level of responsiveness, but then we often repeat that at least every 5 minutes because it can change rapidly. Patients who aren't completely alert, we may also use alert and oriented ×4, may appear confused, agitated, or sometimes even combative. Going back to a physical assessment, as we consider the ears and nose for leakage of cerebrospinal fluid, this becomes an indicator of a skull fracture and suggests a very high impact mechanism of injury. By itself, cerebrospinal fluid is clear and colorless and may be mistaken for another fluid, but if we combine it with our assessment during scene size up of high impact MOI, we may get the idea that neurologic trauma has occurred. In assessing motor and muscle strength, we consider damage to the spinal cord that causes a deficit or neurologic compromise in the extremities. For motor testing, we're looking for movement or strength particularly bilateral strength being equal. For sensation, we may simply touch the fingers of both hands of the patient and ask if they can feel it. Associated with that, we can look for neurologic changes with our assessment of the eyes. We want to pay close attention to any abnormal findings, such as pupils that are unequal or dilated or unresponsive to light. We consider what would be a normal finding using our acronym for assessment of PEARL. We can also assess eye movement by making sure the patient follows our finger with both eyes together in all directions. It's also important to obtain an accurate patient history alongside a complete set of vital signs. We may need to care for both a medical problem and the neurologic trauma that has occurred. If our head-to-toe exam includes other non-neurologic injuries, if we find fractures of the scapula or posterior ribs, a spinal injury may be associated with those because typically these are accompanied by a severe MOI. Remember to reassess vital signs every 5 minutes and carefully evaluate each value, considering the trends that are observed. If we have a traumatic brain injury with increasing intracranial pressure, we may see an increased respiration rate and a slowing heart rate. It's not often that we assess blood pressure in the field, but in a clinical setting, that's possible. Finally, we need to consider findings such as posturing. We may have decorticate posturing, in which we see flexion of the arms toward the midline or adduction, along with extension of the feet. A more serious CNS injury is accompanied by decerebrate posturing, where we get extension of the arms, but still get plantar flexion of the feet.